Good afternoon, everyone. I think we're going to get started. Welcome. My name is Kathy Goss. I'm Senior Vice President for Partnerships and Capacity Building at the American Cancer Society. We are thrilled to have you here today, and I have the distinct pleasure and honor to serve as moderator for our session today, which is called Let's Talk About It, Open Discussions with Cancer Experts. So as you all know, I think May is recognized as Women's Health Month. This month serves as a reminder to women to prioritize their physical and mental health and overall well-being. To celebrate women's health, the American Cancer Society National HPV Vaccination Roundtable, the National Breast Cancer Roundtable, and the National Roundtable on Cervical Cancer, we all aim to foster meaningful discussion around breast and HPV gynecological cancers, crucial topics that impact many individuals and their loved ones. So we're really thrilled to have you with us today, and you're in for a treat. Our panel of experts will offer valuable perspectives, share their own experiences and insights while addressing your questions. So before we begin, a few housekeeping items. So first of all, today's webinar will be recorded. The link to view the recording and a PDF of today's slides will be shared with all who have registered for this webinar. In addition, the recording link will be posted publicly in the future. If you have any issues during today's webinar, or you have questions for our presenters, please use the Q&A. The third point is to ensure that there are no disruptions during the presentation. All participants have been muted by our host. And then lastly, to ensure that we have sufficient time for the Q&A at the very end, we'll be sharing an expanded panelist bios in the chat so that you can have access to those. Okay, let's go ahead and open our discussion. And we're going to have our first presenter, Dr. Shawana Moore. And she will present on the topic of Equity Matters, shedding light on the impact of breast, HPV, and gynecological cancers. So Dr. Shawana S. Moore is a health equity policy leader in women's and gender-related populations. Her advocacy work has truly transformed and shaped women's health curricula, national continuing education to recognize health inequities, particularly for women of color, and those who identify as female. Dr. Moore is the first African-American president of the National Association of Nurse Practitioners in Women's Health, and the inaugural co-chair of the organization's first Inclusivity, Diversity, and Equity Committee. Let's go ahead and have a warm welcome for Dr. Shawana Moore. Thanks for joining us, Dr. Moore.
Thank you so much, Dr. Goss. It's a pleasure to be here to talk about such a critical topic. And I'm really here to set the landscape for our panelists today. So I'll start with my presentation, which is entitled Equity Matters, Shedding Light on the Impact of Breast, HPV, and Gynecological Cancers. Next slide, please. We have two objectives for this brief presentation. One is to really understand equity issues that affect outcomes related to birth, gynecological cancer. Last but not least, I'll be providing some data, some statistical data that highlights the disparities within these different types of gynecological cancers. Next slide, please. So when we think about equity, what is equity? So based on the data, we know that equity refers to the concept of fairness and justice in the distribution of resources, opportunities, as well as outcomes. It really has a huge emphasis to thrive rate, regardless of their background or any circumstances. Next slide, please. So what are the principles of equity? So principles of equity include fairness, equality, non-discrimination, inclusion, as well as justice. And this isn't all inclusive of all the principles. These are just key principles that I pulled out from the literature. So when it comes to fairness, that really focuses on ensuring individuals are treated justly and impartially, regardless of their background and circumstances or characteristics. Equality really focuses on providing equal opportunity as well as resources for all individuals or groups of people, regardless of their socioeconomic status, race, gender, or any other factors. Non-discrimination really focuses on prohibiting discrimination and biases based on an individual's characteristics, such as their race, ethnicity, gender or gender identity, age, abilities, or socioeconomic status. Inclusion really focuses on promoting equal participation and involvement of all individuals in social, political, as well as economic processes. And last but not least, justice involves ensuring people have equal rights and opportunities when it comes to fairness of judgment. And next slide, please. So when we think about social determinants of health, especially when it comes to cancer screening, diagnosis, and treatment, on this slide are several factors that can significantly impact the individual's access to healthcare services, as well as screening, timely diagnosis, as well as treatment options, and really their overall outcomes. And I'm just going to highlight a few key ones that are noted here. So when it comes to access to healthcare, having a limited access to healthcare can really create barriers to timely diagnosis for screening of cancer, diagnosis as well as management. And access can include barriers to transportation, shortage of healthcare providers within a specific area. Another factor, socioeconomic status. So individuals from lower socioeconomic status may face barriers such as financial constraints, inability to take off work to actually make their medical appointments, and limited access to comprehensive cancer care. Also, educational attainment. Often individuals with higher educational attainment may have a higher incidence of being able to obtain those appropriate screening, management, and treatment. However, those from lower may be less likely to participate in cancer screening programs. Race and ethnicity, we know that based on race and ethnicity, individuals from different minority or ethnic groups tend to not have higher screening rates or a timely diagnosis, as well as access to treatment. And some of those factors that really play is mistrust within the healthcare system. So those are just a few I wanted to really highlight in terms of how social determinants of health really has a huge impact on an individual's cancer screening, management, as well as outcomes. Next slide, please. So the first condition, breast cancer. So breast cancer is the most common cancer in women within the United States. It accounts for about 30% of all new female cancers each year. It is also the second leading cause of cancer death among women. The good thing is that since 1989, overall rates of breast cancer have steadily declined. So about it declined overall about 42% through 2021. And this is data based on American Cancer Society. But as of 2024, it's estimated that a little over 300,000 new cases of invasive breast cancer will be diagnosed in women, a little over 56,000 new cases of ductal carcinoma in situ will be diagnosed, and a little over 42,000 women will die from breast cancer in 2024. Next slide, please. When it comes to inequities, there is huge disparities in inequities when it comes to breast cancer. Based on the data provided by the American Cancer Society, the median age of diagnosis is slightly younger for Black women, around age 60, when compared to white women at age 64. Black women have a higher death rate when it comes to breast cancer. This may be partially due to the higher rate of triple negative breast cancer that is particularly high among Black women, more than any other race or ethnic group. However, based on the data, at every age, Black women are more likely to die from breast cancer than any other race or ethnicity. White, Asian, and Pacific Islander women are more likely to be diagnosed with localized breast cancer than Black, Hispanic, American Indian, and Alaskan Native women. And last but not least, Asian and Pacific Islander women have the lowest death rate for breast cancer. Next slide, please. So HPV-related cancers, and for this particular slide, I'm really going to hone in on anal cancer, oral pharyngeal cancer, as well as penile cancer. I'll touch a bit on vulvar and vaginal cancer on the coming slides. But for anal cancer, it's a rare type of cancer. It's one compared to colon and rectal cancer, based on American Cancer Society data for 2024, specifically within the US. There'll be a thousand will die from anal cancer. Of that, 1,000 will be men, and a little over 1,000 will be women. So higher rates among women when compared to men. For oral pharyngeal cancer, based on American Cancer Society most recent data, we know that about a little over 12,000 new cases will occur in 2024, about 10K or 10,000 in men, and a little over 2,500 in women. And about 3,800 will actually die. And of those 3,800, a little over 3,000 will be men, and about 760 is estimated for women. Okay, and then I just want to touch on briefly penile cancers. Although it does not affect women, it does have an effect on men. It is estimated as of 2024, there will be about 2,100 new cases, and about 500 deaths will occur in 2024. And next slide, please. So when it comes to inequities, specifically around anal cancer, so it is more common in white women and in Black men, specifically anal cancer. There are really a lot of inequities and disparities around anal cancer. A lot has to do with individuals that may come from a lower socioeconomic status, risk factors for HPV, also screening and early detection, as well as treatment disparities that do exist. When it comes to penile cancer, it's really rare in North America and in Europe. It's typically diagnosed in fewer than one man in 100,000 each year. It's really prominent in some parts of Asia, Africa, as well. I'll move on to the next slide, please. So moving on to gynecological cancers and looking specifically at ovarian cancer. So again, based on data from the American Cancer Society for 2024, it's estimated that a little over 19,000 women will receive a new diagnosis of ovarian cancer in the US, and about a little over 12,000 women will likely die from ovarian cancer. Ovarian cancer is one of the leading causes of cancer deaths among women in the US. For cervical cancer, it's estimated that in 2024, there will be about 13,000 new cases of invasive cervical cancer, and a little over 4,000 of those cases will result in death. When it comes to endometrial or uterine cancer, and this is cancer that affects the uterine lining or the uterus, it is a common type of cancer, and within the US, I'll provide some data on that. So as of 2024, based on American Cancer Society, about 67,000 new cases will be diagnosed, and of those 60,000 cases, about 13,000 of those cases will result in death. When it comes to vulvar cancer, which again is a rare gynecological cancer, it accounts for about 6% of female cancers. But for 2024, the data says there'll be about 6,900 cases of vulval cancer. Of those cases, about 1,500 will result in death. And last but not least, for vaginal cancers, again, this is a rare type of gynecological cancer, but for 2024, it's estimated that there will be about close to 7,000 cases, and about 1,600 will result in death. Next slide, please. So inequities exist for all types of gynecological cancers. When it comes to ovarian cancer, it's more common in white women than Black women. However, Black women are more likely to die. For cervical cancer, the death rates in Black women and Native American women is about 65% higher than white women. For uterine and endometrial cancer, it is based on the data, it says Black women are more likely to die when compared to white women. For vulvar cancer, again, there's a higher incidence in Black women when compared to white women. And last but not least, for vaginal cancer, Black women have a higher rates when compared to any other race or ethnicity. And next slide, please. So what does this all matter? So the biggest thing is ensuring equity in the prevention, screening, and diagnosis for treatment of breast cancer, HPV-related cancer, as well as gynecological cancer is really critical and crucial for health outcomes to help reduce these inequities within healthcare. Some key points when it comes to breast cancer, it means ensuring that your patients have access to equal access to screening mammograms, early detection programs, as well as diagnostic services and treatment regardless of their race, ethnicity, their income, or their geographical location. For HPV-related cancer, again, is ensuring that your patient populations have access to timely cervical screening, that you're following the cervical screening guidelines. For gynecological cancers, it ensures that barriers are addressed that prevent screening as well as diagnosis and treatment. Also that patients have access to survivorship support programs for the various types of gynecological cancers. So when we really promote equity within these types of cancers, we really help to eliminate any disparities and inequities within our healthcare system, and we ensure our patient populations have access to quality cancer care or cancer prevention. And it really ensures that our communities are overall healthier and that they thrive. Next slide, please. And these are the references. And that ends my presentation.
Sorry, I am on. I was just having some trouble with the camera. Dr. Moore, thank you so much. That was a fantastic overview and presentation. It really helped level set about the disparities that certain populations face and truly the overall impact on breast, HPV, and gynecological cancers, and why an event like this is so timely and really, really important. So I'm really thrilled that we get to move on to our panel discussion now. We've got a fantastic lineup of panelists. And so I will give you a brief introduction of Dr. Erica Hamilton, Dr. Amy Weiser, and Nancy Pena. But as a note, their expanded bios have been provided in the chat for you. So let's start off with Dr. Hamilton. So Dr. Hamilton completed her medical degree and residency from the University of North Carolina in Chapel Hill and fellowship training in oncology at Duke. She joined Sarah Cannon Research Institute as an investigator in drug development for women's cancers in 2013. Since 2015, she's been director of the Breast Cancer Research Program. She sees patients facing breast cancer from standard of care to phase 2 and 3 and phase 1 drug development. And she currently serves as ASCO's ASCO's Cancer Research Committee and will be the 2025 ASCO annual meeting scientific chair. That's a big job. So congratulations on that. She is also on the 2023-2025 scientific committee co-chair of the ESMO breast cancer meeting, is on the scientific committee for AACR for 2023. She serves as associate editor for clinical breast cancer. So there's a lot going on. Dr. Hamilton, thank you so much for joining us. I'm going to go ahead and finish with the additional introductions, and then we'll jump into our questions. So our next panelist is Dr. Amy Weiser, she, her pronouns, and she's a family medicine physician in Portland, Oregon. She completed her undergraduate studies at Penn State University and earned a medical degree at Drexel University College of Medicine. After graduating from family medicine residency training in Pennsylvania, she completed her OB fellowship through the University of Washington in Spokane. Dr. Weiser started her career as a full-scope family physician in rural Oregon. In 2022, Dr. Weiser joined Cascade AIDS Project and practices at Prism Health, a lookalike FQHC primary care clinic focusing on LGBTQIA plus health and HIV treatment in Portland, Oregon. Welcome, Dr. Weiser. Our last panelist, last but not least, is Nancy Pena. So Ms. Pena works as a lead patient navigator for the gynecologic oncology clinics at Dana-Farber Cancer Institute and Brigham and Women's Hospital in Boston. Ms. Pena is also the director and founder of Patient Navigation International, an organization that trains clinical and non-clinical patient navigators in Spanish in Latin America. In addition, Ms. Pena has produced a local television show, Colores Latinos TV, for the past 10 years to educate Hispanic communities on the importance of prevention and early detection in healthcare, and provides discussions on available resources. So important. Thank you so much for being here, Ms. Pena. So thank you all so much. What I'd like to do is really jump in, and I'm going to sort of stay with the order, at least for the first question for each of you, as I introduce you. And so let me jump in with Dr. Hamilton. I would love to hear a little bit more. Let's focus for a moment on early detection and screening. Can you help us understand why regular screenings for breast cancer and early detection are so important? And then I would love to jump in a bit about risk as we're thinking about screening and reducing risk through screening. Can we talk a little bit about some of the things that can reduce our risk overall in developing breast cancer, like screening? So Dr. Hamilton.
Yeah, absolutely. So, put really simply, screening is important because we want to catch cancers earlier when they're more likely to be cured, right? So we certainly want to catch cancers before they spread outside the breast and the armpit to the rest of the body. But even beyond that, even catching a cancer when it's 1 centimeter compared to 4 centimeters, a lot of times therapy is easier for smaller cancers, perhaps maybe not even needing to undergo chemotherapy, or therapy that's a little bit easier to get through. So that's really why we focus on early detection, is because we want to cure people of cancers. We don't want them having to live with their cancers and being on treatment. Interestingly, this is a timely question because the U.S. Preventative Services Task Force just issued an updated recommendation around breast cancer screening. Multiple other organizations, the American Cancer Society, American College of Radiology, OBGYN organization, had all agreed that we really, at a minimum, should be starting our mammograms at age 40. So the United States Preventative Services Task Force is now in line with that. Previously, their recommendation was actually 50. And so now it's pretty well established across all organizations that we should be starting mammograms at least by 40. And I say at least because there are circumstances where somebody may need to start earlier. Somebody that had breast cancer in their family early, somebody that's known to have a BRCA1 or 2 gene mutation, or somebody that had radiation or certain types of cancer as children. So really, it's a discussion that's individualized. So somebody should talk to their physician about what age may be appropriate for them.
Thank you so much, Dr. Hamilton. Super helpful. And I'm also just wondering, as you're talking about screening, really as a way to reduce risk, obviously, and make sure, as you said, that if we can catch a breast cancer early, that the outcomes are better. Can you tell us briefly, I know that this is, there's a lot to this, but can you tell us briefly about any other preventive measures for breast cancer or lifestyle changes that can reduce someone's risk?
Yeah, absolutely. So I'll say that I really like the word risk reduction because I think sometimes inherent in the word prevention is this idea that you can prevent cancer. An individual can't prevent cancer, over, everyone that's living kind of a global scale, we can talk about prevention, but for each individual, it's really risk reduction. There's nothing you can do to guarantee that you're not going to get cancer. But behaviors, there's some things we know that we can control and some things we can't. So family history, we can't control that. Whether you've had a previous radiation, whether your breasts are dense, we can't control those. Things we can control is alcohol intake. We really recommend not having more than 1 drink per day for females. Maintaining normal body mass index can also reduce risk. And so there are some things we can prevent and some things we can't, but we really talk about risk reduction.
Terrific. Thank you so much. Okay, we're going to turn to you, Dr. Weiser. And as we're talking about reducing risk, I'd love to turn to the HPV vaccine. We know how important that is as a way to prevent HPV-associated cancers. Can you tell us a little bit more about the power of the vaccine and, really, we've heard some things, there's some things going out there around the different, the 4-valent vaccine versus the 9-valent vaccine, and then even starting HPV vaccination in a younger population. I would just love to hear from you sort of what is the state of the science and what does that tell us, and how do we sort of arm ourselves with the most cutting edge information, because it can get a little confusing out there.
Yeah, it definitely can get confusing out there, especially as things keep changing, which, in our field it does. So a bit of the background is that the HPV vaccination has been out since about 2006. It was out previous to this in Europe, but it was FDA approved going on almost 20 years ago. And when it first started, it didn't include all of the variants of HPV that it does now. So one of the more popular ones had a 4-strain coverage. So it was called the quadrivalent one. And I think that this was very popular for a long time. It was essentially the vaccination that was available. As we have grown in our technology and understanding of HPV, our vaccinations have also improved with time. So the current vaccination that is out, and it's actually the only one on the market now, covers 9 different genotypes of HPV. 2 of them are lower risk types, 6 and 11, and that covers for things like genital warts. And then the other 7 cover more of the higher risk strains of HPV that are more closely associated with pre-cervical cancer changes, as well as cervical cancer. One of the things that comes up is, well, these vaccinations, what if you started with the quadrivalent, the one who has 4 strains, but now only the nonavalent, or the one that contains 9, is on the market? Do we have to restart the vaccination? And honestly, the studies say no, that we don't need to, that this is an expansion of the goodness that was already included in the quadrivalent. And so there's no need for revaccination. What we're really pushing for now is when to start the vaccination, and it's indicated to start at age 9. I think that in years past, we had sort of bundled it with vaccinations that are due for adolescents around the age of 12. And now we really want it to be a standalone, to be so important that this is the reason to come in for a well child check, to have this 9-year-old vaccination. If we start vaccinations prior to the age of 15 for any young adolescent, they need 2 doses. It's a 2-dose series. Versus if we start after age 15, it's a 3-dose series. It's always easier to get just 2 doses in than 3 doses in, especially for adolescents and before they get really busy with later adolescent schedules. So we do a lot of counseling. There's a lot of marketing campaigning about starting earlier for age 9. The ACS HPV Vaccination Roundtable has amazing toolkits and information out for providers as well as patients. And so making sure that this concept, vaccination, is part of our daily counseling as we see patients in the office is really empowering so that we can get word out and people vaccinated to try to prevent HPV related cancers.
That was, you just summarized a lot of information in just a short amount of time, and it was really, really helpful. I really appreciate what you said towards the end there about, really making sure that our clinical workforce is promoting vaccination starting at age 9. Do you have an idea? You mentioned about some resources that the HPV Roundtable has put together to encourage clinicians to support, to prioritize age 9 vaccination. Do you have an indication of what works? How do we better equip clinicians with those resources and tools, and what can, through your experience and work with the Roundtable, are there things that ACS and other organizations can continue to do to really to help our clinician workforce, healthcare workforce, get those vaccinations started early?
Yeah, right. There's a lot of things coming at us in the primary care office all of the time. So how do you prioritize this? And I think that a lot of it is amplification from providers who are strong advocates. The ACS HPV Vaccination Roundtable has beautiful toolkits available. CDC has You Are the Key to HPV prevention. Slide decks available too. But I think that one of the important things is usually in primary care offices, there's a vaccination champion. There's the person who orders the vaccines, who keeps track of them. And that is a key person to engage so that they understand what this vaccination does. It is a cancer prevention vaccination, and really empowering somebody that you work with in the office, like a vaccination champion, to make sure that everyone in your office is educated, right? From the front office staff to medical assistants, nursing staff, so that we're all on the same page, that there's no conflicting or misinformation giving to patients, and make it part of just your standard workflow.
Awesome. Thank you so much. Okay. Ms. Pena, thank you so much for joining us. And, we know how important patient navigation is to the whole cancer journey for individuals who are facing a cancer diagnosis, but certainly even through screening, and all the way through that care continuum. I would love for you to share with us a little bit more about what navigators do, and maybe a great way to illustrate that would be to help walk us through what happens. We were just talking about HPV, and we're going to talk a little bit more in a bit about cervical cancer in more detail, but maybe an example of what happens if I have an abnormal cervical cancer screening, for example. What does the patient navigator do?
Yes, thank you. Before I get started, I would like to share a slide that I have for you guys to share about our mapping in our clinic. Well, as we know, and the CDC also explains that disparities, caused by poverty, stigma, and discrimination, and lack of education can definitely contribute to poor health outcome. Patient navigators, we are here to support patients and advocate for them. And this mapping flow that we have in our clinic, I just want to explain quickly and answer perhaps your question. 2 years ago, we began with this QI project where we were looking with two different clinics. One clinic was the General Gynecology Colposcopy Clinic here at Brigham and Women's, and the second clinic was the Pap smear evaluation center where I work at Brigham and Women's. And we partner with those clinics to see how we can address those barriers for patients who are lost in the follow-up, right? Because most of the time, when you have abnormal funding, sometimes, unfortunately, some clinics doesn't follow up with you, and sometimes patient doesn't follow up about the results either. So in this mapping, what we discussed was to centralize a protocol to ideally through the EPIC. So in EPIC, we can check box and to communicate between clinics and make referrals saying that this clinic, this patient is a higher risk patient. After that, part of the protocol, the Department of OBGYN also contact the patients, request records from different clinics if needed, and also they determine the clinic urgency to see this patient in one of the two GYN clinics, colposcopy clinics I mentioned it before. When that happens, the nurses will also enter prior abnormal funding or biopsies, and they will contact the patients to book an appointment to review results, but also to educate the patient about what is this visit. We learn in our clinic that a lot of patients, sometimes they are being referred from different health centers and they don't understand why they are being referred to our GYN oncology clinic. And when they came to our clinic, they are very frustrated. So our nurses educate those patients, but also what we implement in this mapping was that nurses are assessing for barriers, right? So they are asking, and we have 8 determinants of health mentioned in transportation, housing, childcare, etc. So the nurses ask those questions. If they see that the patient has any barriers, immediately they refer that patient to me or the navigators in the different clinics. And from then, we take care of that patient. We follow up with the patient in our clinic. Usually we call 3 weeks early before the first appointment in our clinic to assess barriers, right? If the patient has any barriers, we also assess if they are eligible for different resources we have here at Dana-Farber and Brigham and Women's Hospital based on income. Some of those resources could be set up an Uber, provide more education, and sometimes we learn also that it is not clear for the patient, even though they already speak with the nurse, sometimes they have more questions. So we are the bridge between the patient and the medical team to translate those questions and for the patient to have a clarity information when they have to follow up. Besides of that, we also have a protocol in when the patient doesn't show up or doesn't follow up. 8 years ago, we published an article about reducing the no-show rate in our clinic from 49% to 29%. Today, I can tell you that perhaps our no-show rate is 8% or 10%. But that happens because we implemented a different QI project. When we call patients to reschedule an appointment, we don't just call them to reschedule. We ask them why, what's the reason, or what happens to them that they didn't follow up. In that study, we found 26 reasons why patients didn't follow up. The first reason was I forget the appointment. The second reason was I had menstrual period. And the third was I didn't remember about the appointment. So now our clinic anticipates those barriers. And when we call patients to reschedule appointments, we ask about menstrual period, right? Just to see if that appointment is not going to match with that situation. And I just want to give a brief example, and we have a case here about a safety net project. This is mapping in this slide. One of the patients was having a baby. She's a refugee lady, 32 years old from Haiti, with high-risk cervical cancer. After her pregnancy, the clinic, OBGYN, found that she has a high risk of cervical cancer. She has no transportation, no family support, just her husband, and she just had 3 months in the United States. And she doesn't understand why she has to follow up with us after having the baby. So the intervention of navigation was to call this patient almost 18 times before her first appointment. Why 18 times? Because she was having a lot of questions. Her husband has questions also about the procedure. And they don't understand the health system in the United States. Remember, they are just 3 months in the United States and they are refugees. We were able to provide them with transportation and support, and also escort the patient from the lobby to the clinic, because she explained that for her it was very confusing to navigate those huge hospitals in the United States versus her health center in Haiti. And she needed a loop procedure. The loop procedure is an electrical procedure that remove abnormal cells. But remember, after a loop procedure, patients cannot have intercourse for 1 month. So she was worried about that, how she's going to communicate that to her husband. So we finally have a meeting with her husband, the nurses and the doctors, and explain that she needs this procedure to save her from cervical cancer, and also not to have intercourse for 1 month. After those interventions, the husband support her, and she finally had the procedure. But again, every time she has to come back and follow up with us, I had to meet her at the lobby. And that's navigation, right? To wait for her, we have a way to see what the Uber is coming in our platform. And when I see that she was almost 2 blocks from here, I had to walk to the lobby, wait for her, and bring her back and forth. And even though she perhaps knew the way, she was, requesting that services, and we were able to provide that. So I'm going to stop here because I think, I'm so passionate about navigation, but that's one of the examples of how navigators can help patients in general.
What a powerful example that was. And that really resonates, I think, probably with so many in the audience that have joined us. I would love to just hear from you. How do people typically connect with a navigator? And very simply, do you have to have cancer? Do you have to have a cancer diagnosis to be able to work with a patient navigator?
Yes, thank you. For the first question, how you connect with the navigators. Well, we can ask in our clinics, right? If the hospital or health center has a navigator, or even a case management, it's very similar. If we don't have a navigator in the clinic, we also can ask for a social worker. And you don't have to have cancer to have a navigation services. Right now, we have to remember that the Biden administration just passed this new rule to reimburse patient navigation services, right? And in March, also, they announced that private companies, private health insurance will also reimburse for patient navigation services. So that means that navigators are going to be hiring more right now in different areas. We have navigation in the emergency room here, and we have navigators that support diabetic patients, cardiac issues patients, etc. So you don't have to have cancer to have a navigation services.
Great, thank you. And I'm going to tee up a question for you. We'll come back to you. But I would love to talk a bit about what happens if someone's hospital, someone's clinic does not have navigators. What do you recommend there? So that's just to give you a little teaser. So I'm going to go back to Dr. Hamilton. You talked really clearly about the importance of reducing cancer risk, and I would love to dig into a bit about genetic testing and why that's important in assessing breast cancer risk, and how does it assess risk, and who should consider undergoing genetic testing, because I know there's a lot of information about that out there, but again, sometimes it can be a little confusing about sort of who fits in that sort of profile as someone who should undergo testing.
Yeah, I think that's a really important question. And honestly, it's not completely straightforward. It's been a little confusing over the years. I'll say that now in 2024, many more people undergo genetic testing than we used to have. And that's really because we have approved drug PARP inhibitor, especially for breast cancer, that's higher risk for people that have a BRCA1 or 2 alteration. So now that there's a linked therapeutic, it makes sense really to test even more people so they potentially could be eligible for that. Separate from that, really, it's based on family history and the age that you're diagnosed with cancer at. So if you're less than 50 and you get diagnosed with cancer, that's an appropriate person to do genetic testing for. Similarly, if your family pedigree has a lot of breast or ovarian cancer in it, that's another way people qualify for genetic testing. If you've had 2 breast primaries or actually any personal ovarian primary, that's another reason people qualify for genetic testing. Now, all of that being said, I think that there's this misperception that most people that get breast cancer have a genetic risk, that they have a BRCA1 or 2 alteration, and that's not the case. So, less than 10% of our breast cancers in the United States have anything to do with a BRCA1 or 2 alteration. So said a different way, the majority of people diagnosed with breast cancer, 1 in 8 women now will be diagnosed with breast cancer, really don't have risk factors to point to. They don't have an alteration in BRCA1 or 2, and they're really kind of more average risk. So that's really said that nobody is completely safe. And that's really the reason that screening mammograms are so important, is to identify these cancers early when they're very easily treated and most likely to be cured.
So that was really, really helpful. Can you speak to but any sort of misconceptions about factors that can contribute to higher risk of breast cancer? I know we've heard especially in the public media or even social media and other circles about, things like antiperspirants or underwire bras or, having large breasts, how that all contributes to higher risk of developing breast cancer. Can you speak to any of that so that we are a bit more informed and can, inform those around us in our own networks?
Yeah, absolutely. So somebody with smaller breasts are not less likely to get breast cancer than somebody that has larger breasts. Your bra or undergarment choice is not going to give you breast cancer. It's true. A lot of times somebody comes in and they said, oh, I fell or I bumped my breast on the kitchen cabinet, or I wore this really uncomfortable bra on an overseas flight and I noticed this mass. None of that really caused the breast cancer. It was just whatever happened, that somebody might have actually been touching the breast to feel that and notice that it's there. Antiperspirants also don't cause breast cancer. Deodorants don't cause breast cancer. It's interesting, actually, certain diets don't have a lower risk of breast cancer. So somebody that's vegetarian or vegan or eats meat or eats low carb, really diet isn't linked to breast cancer. Certainly physical fitness and maintaining normal body weight can be quite helpful. We know that people that have more body fat have higher circulating levels of estrogen, because our body fat actually converts normal steroids into estrogen after menopause. And so that can affect somebody's risk recurrence for breast cancer. But those things that are kind of the wives' tales, in fact, do not cause breast cancer. One thing that is more recognized now is breast density. Women that have a higher breast density are more likely to have a cancer, and unfortunately are more likely to have that cancer hidden, maybe on a traditional mammogram. And so there was actually a pretty big breakthrough that now in all states, it's mandated for your breast density to be disclosed to you on your mammogram report. So now everyone should know if they do have particularly high breast density. And if so, then that's a conversation to have with your provider of, is there additional screening I need to do? Because there are other tests we can do for people that have higher breast density.
Okay, we're going to come back to you, Dr. Hamilton, about some information around clinical trials. So That's your teaser. Okay, so we're gonna go back to Dr. Weiser to follow up on some things that you were sharing about the HPV vaccine. One question here is around, would HPV vaccination provide any benefit to me if I've had an abnormal cervical cancer screening test? Oh,
Oh, all right. I got the button. I'm clicked. Yeah. So say you do have an abnormality on your screening, on your cervical cancer screening test. We think about having the vaccination between the ages of 9 and 26, and then after the age of 26 up to age 45. It's really a shared decision-making conversation, meaning that we think about risk factors that our patient may have. We talk about these. It's not a clear recommendation. So, there are clear recommendations for some vaccinations. We recommend everyone to have the flu shot yearly. We recommend COVID vaccination. But between the ages of 26 and 45 for HPV vaccination, it's a little bit differently. It's not universally recommended. So if a person has an abnormality on their cervical cancer screening and they haven't received the vaccination, should we be thinking about this? Most of the studies are supporting, well, we are gaining information each and every year, it seems, but of the studies that are available, there is a thought of having an adjunctive HPV vaccination after you've had treatment for an abnormality. So this doesn't include people who have a mild abnormality, come back in a year for a co-test. This is more after a person goes for a colposcopy and actually a therapeutic procedure as well. So there is some advantage of having the vaccination, not so much as a treatment, and that should be clearly communicated with the patient, but to try to prevent any other HPV changes that may occur if a person is exposed to a different type of HPV, right? Because there's so many out there. And so we're thinking about a collective secondary prevention with the vaccination if possible. But really, it does go back to shared decision making, as most of these patients are going to be older than age 26 and may or may not have had the vaccination. If a person does have an abnormality and they have received the vaccination, that's not a reason to redose. You don't need a booster dose for HPV. Studies have not recommended that.
So let's sort of shift from the vaccine to testing. So there's some recent news about self-sampling and self-collection. I know this is a topic near and dear to your heart, and I would love for you to sort of share with us, what does that mean? How do we, who benefits from that? How does self-collection happen? And can it happen anywhere? So in other words, at someone's home, or does it need to be in a physician's office or clinic or a pharmacy or something like that?
Yeah. This is a super hot topic. The FDA just approved this month, actually, for primary HPV self-collection. And I think that it gets a little complicated and a little nuanced. So I'm going to take the opportunity to kind of step back for a second and level set, because we need to make sure that what we're offering is truly what we can be offering and that everyone's on the same page. So there's 3 ways to screen for cervical cancer. There's the traditional PAP that gives us cytology or cell sampling. There is co-testing, which is it's the PAP, it's cytology, as well as HPV results. And then there's primary HPV testing, and I'm going to focus on that for a little bit. Primary HPV testing was FDA approved about 10 years ago in 2014. But most of us haven't really moved to using primary HPV day in and day out. And there's a couple of reasons for that. Until the 2020 ACS guidelines for cervical cancer screening, it wasn't put forth as a preferred method in order to collect the screening. We know that as things go from acceptable to kind of preferred, that is a push for payers, for laboratories to get on board and try to change infrastructure so that is the test that is used most frequently. It costs a lot of money and it takes a lot of time to get there. One of the bright points of COVID, which no one has ever said bright points of COVID, but I'm going to in this context, is because some of the lab equipment that came into play in order to screen for COVID, those machines can also screen for HPV, for primary HPV. And so that may be a secret bright spot that we now have that infrastructure building up so that primary HPV testing can be the preferred way of testing and more mainstreamed in the next few years, becoming this is the way you screen for cervical cancer. So why am I babbling on about all this? Well, it has to really do with self-collection. In order to have self-collection, your lab setup needs to be based on primary HPV. And there are 3 different machines that can run primary HPV. So you have to have the right machine. You have to be in contact with your lab to set up all those moving parts. And self-collection is not approved to be done in the house yet. So I think about colon cancer screening, where sometimes your health provider or even your insurance company, if you have insurance, may send you like a colon cancer screening kit in the mail. We're not there yet, but we would love to be in the next few years. So for this period of time, really what we're doing is self-collection in the healthcare setting. So a patient would come in to see me, and I would have the proper swab and the proper setup with the lab that I could offer this to them. And they would do a self-swab. They would place the swab in the vagina. It doesn't have to collect cervical cells. So that PAP, that crampiness, if you have a cervix, it doesn't need to collect those cells. Really what it's looking for is HPV DNA, that genetic material that is in the vaginal area on the cervix. And so that's why a self-swab can be collected. So that's what the self-swab is. And then ultimately, we do hope to be able to have patients do this at home. It's a great method of reaching patients who maybe have a lot of different barriers. And I think Nancy really spoke to many of them, so I'm not going to belabor that. And also to patients who have a lot of trauma associated with a speculum exam, which even if you don't have any sexual assault trauma, this is a really invasive exam. And so we're hoping to really empower people to have these screenings done, to have it done in as least invasive way as possible, and to have them be in control of that particular screening. Having an abnormality in this screening, a lot of times they are going to need to come back for more of that traditional speculum collected cervical cancer screening. But really, as we move forward with self-collection, we'll get more down to the nitty-gritty, the nuanced steps. But this is really exciting for all of us involved. And I have to disclose that I did talk about the HPV vaccination roundtable. I am not on that roundtable. I'm actually on the National Roundtable on Cervical Cancer, but so many things are intermingled with HPV vaccination roundtable. But this is definitely something that the Cervical Cancer Roundtable is working a lot on. To then actually make sure that we are educating providers as well as patients to ask for these and how to properly conduct the self-collection.
That was great. And I can see why there's so much excitement about this. It's a huge step forward. And, the goal is to get as many individuals screened as possible. And so, hoping that this really pushes the needle and it's going to continue to be refined and be more accessible. So that's really exciting. I also appreciate you giving a shout out to the ACS Roundtable on Cervical Cancer and all their important work. Our roundtables are so critical for building that coalition of thought leaders and experts and organizations, bringing them to the table to really push the envelope, and especially when it comes to addressing barriers to care. So appreciate all that you do, and all of our volunteers here that are serving on this panel, as well as across the country that works so hard as part of that coalition on our roundtables. So, okay, Ms. Pena, we're going to turn back to you. I'd love to address this question of, unfortunately, we know that navigators aren't available everywhere, although what you beautifully pointed out is that as things like reimbursement come into play, we're hoping that that really makes patient navigation in oncology more sustainable and more readily available to everyone who needs it. But what happens today if somebody would benefit from those services and have tremendous barriers to care, but don't have access to patient navigators? What do they do?
Yes, thank you. Well, some of the resources that most hospitals and clinics has is a social worker, right? So social workers also can help to navigate and provide resources. Also, community health workers who are in the community can support patients with resources, right? And some hospitals like Dana-Farber, also we have resource specialists or financial counselors. So those roles can definitely perhaps not fit until the like a navigator, meaning like the navigator is gonna go with you or support you during the visit, but also they will help you to find resources into the community.
That's great. I would love to dig into the workforce, the navigation workforce. So can you describe, there are all sorts of different types of folks who work in navigation. You mentioned, especially in centers that don't have bona fide patient navigators, there's certainly social workers who serve some of the functions. Can you tell me a bit about what are those different kinds of navigators and what are their roles, and who becomes navigators?
Sure. So we have a variety of navigators right now. We had to go back to 1990 with Dr. Harold Freeman and started the lay patient navigator, right? He was working with breast oncology patients, African Americans specifically, and he built this model for non-clinical navigators. So we have non-clinical navigators who are professionals who are, being trained to become navigators, and they can definitely connect the patients to community resources, also communicating with health professionals on the patient's behalf, assisting with administrative tasks such as scheduling appointments and organizing, perhaps not medical records, but organizing the appointment, right? Just to set up the stage if we have a specific patient, as the patient I mentioned it to you before, right? We have to set up the interpreter before the patient is arriving, just to have everything in place and aware the team about the needs or the barriers of these patients so the whole team can communicate at once and support a patient. That's the professional non-clinical navigators. We also have right now community health workers. Community health workers were before navigation, right? Community health workers historically has been supporting communities to access healthcare, supporting them with resources, health education, advocates for individuals and community health needs, and providing some direct services such as first appointment or perhaps a first appointment for assessing blood pressure screening, diabetic screening. So we also have community health workers who were the first in this field. We also have nurses and social workers navigators now, right? So nurse navigator is a person also, then if you don't have a non-clinical navigator, going back to your first question, you also can ask for a nurse navigator. Right now we have nurse navigators who historically also, they decided to navigate patients in 1970. I was just reading an article from Lilith Shaknek, who is the co-founder of the Academy of Oncology and Nurses and Navigators. And she was describing that nurse navigator started in 1970. They were reviewing charges, a patient's charge to see what virus they have in a long time ago. And the nurse navigator versus the non-clinical navigator, as the name says, right? Non-clinical, we don't deal with clinical issues or give information or like any clinical information. We are not allowed to provide that to the patient, for example, results or potential surgeries. But nurses, they do, right? So nurses are able to discuss clinical situation for health, for example, side effects of chemotherapy, radiation, what medication to take, how to apply that medication, etc. And social workers also, we have social worker navigators who are supporting patients psychosocial, right? They are providing psychosocial support, but also they are providing resources. So as we can see, we have a variety of type of navigations right now. And I believe that we will have perhaps more different type of navigators, perhaps financial navigators, right? We have financial navigators supporting patients when they're coming. We also, it's important to mention that right now, because navigation is in a great position right now, it's a momentum for navigation. We also have private navigators. We can provide private services, perhaps not for low-income patients, but for patients who are struggling to manage healthcare. International patients, we can say that. I have a colleague in Miami that run a private program, navigation program, and she is working with international patients coming to the United States for care. So those are the type of navigators we have. In terms of perhaps the next question might be training, right? How can I have a training on navigation? Well, there is a different type of trainings right now. We had the George Washington Cancer Center, we had the American Cancer Society training, right? We just launched a new training also to learn about navigation and how to become a navigator.
Yeah, that was a terrific overview. It's complicated and a changing landscape in navigation, as you said. It's such such a impressive time right now with a lot of momentum, and I think you really summarize sort of the state of things really beautifully. So thank you so much for that. I'll also give a quick shout out to speaking of roundtables and the power of roundtables. The American Cancer Society National Navigation Roundtable is again a really powerful coalition of organizations and individuals, thought leaders that work on this issue of sustainability of navigation, of policies that support robust oncology navigation for patients across the care continuum. So it really takes a village to move the field forward, and it is built on a tremendous amount of work and body of evidence supporting the impact of navigation. So thank you so much for giving those fantastic insights. I think we have time for one more question for each of our panelists, so I'm going to be choosy on these questions. But I would encourage the audience, if the folks who have joined us, if you have a question that we have not discussed yet, feel free to just a reminder to put it in the Q&A field as part of this Zoom webinar. And we're trying to answer as many questions through that as well as answering them live. I'm going to go to Dr. Hamilton. I warned you that I was going to ask about clinical trials because I know that's such an important space that people want to hear about. I would love to hear from you about, what are some sort of emerging therapies or clinical trials that are showing promise, especially in advanced or metastatic breast cancer, where we know we have some, very few options from a therapeutic standpoint and a tremendous need for new approaches. And then as a sort of secondary question is who is appropriate for a clinical trial, especially for those trials for advanced breast cancer?
Yeah, so I may start answering this in early cancer and then I'll go to metastatic cancer. So
Perfect.
to the second question, everyone is appropriate for a clinical trial. Not everyone may qualify for a variety of reasons, but there are trials for people with incurable breast cancer. There are trials for people that have already completed their treatment and maybe are just in surveillance and we're monitoring the blood for markers that can indicate cancer. There are trials for people that have not received treatment yet, where we're trying a new therapy versus something standard. There's actually been a big breakthrough through a clinical trial that actually had nothing to do with the therapeutic at all. It was a test called Oncotype DX, trying to figure out if we could figure in the actual cancer, are there certain genes and a signature that would predict less likelihood of cancer coming back, where those women wouldn't need chemotherapy. And that was actually successful. And so for the past several years, there's a lot more women with ER positive disease that ultimately don't need to have chemotherapy. So in the metastatic setting, there are new drugs, I like to say coming every day, but literally we have 3 to 4 drugs approved a year for metastatic breast cancer. One of the really big hot classes of drugs right now are something called antibody drug conjugates, where chemotherapy is fused to an antibody through a special linker. And so we like to call this the smart bomb. It delivers chemotherapy preferentially to cancer cells that express that target and kind of leaves the rest of the body alone. And so they're more effective because we can attach kind of stronger chemotherapy to them, but they also tend to be better tolerated because we're not getting all of those side effects on normal healthy cells that we're not targeting. So we currently, there are 12 antibody drug conjugates approved in oncology. 6 of them are for solid tumor, and breast cancer actually has 3 of the 6, which is fantastic. And there are many more coming. So we have 2 right now for HER2 or HER2 low, 1 for TROP2. And now we're getting even smarter with this technology. Could we even attach an immunotherapy molecule on it instead of a chemotherapy molecule? What about, instead of just targeting one antigen, a bispecific, where we're targeting 2 different antigens on the cell surface to help with resistance? And so we have ASCO starting later this week in Chicago, where we'll hear a lot about antibody drug conjugates and new advancements. So stay tuned.
Awesome. Yeah, can't wait for ASCO. It'll be really, it's always such a treat to see sort of what's on the horizon and what looks promising, and you know, what does the future hold in terms of cancer treatment and the results of these trials. So that will be, you know, something to keep an eye on for sure. Dr. Weiser, I'd like to turn it to you to talk about, we heard, I actually have 2 questions for you. I know I said just one, but I have 2 for you. Just because I want to make sure that we have time to talk about, we've mentioned sort of in passing an abnormal screening result for cervical cancer. And I really want to sort of understand, what does that mean? And sort of what are the next steps following an abnormal result?
Yeah, the answer to this question is not exactly streamlined. So I will do my best to make it understandable. But I want to start with the provider perspective of an abnormal result, because I really want to just say that we speak to each other in acronyms that become words, and it's not normal. I mean, our language patterns, after we go through all of our training, are very abstract to most people. And even if I'm talking to a provider who doesn't do a lot of GYN or gynecological based care, they're not gonna quite understand what I'm getting at on the first go. So I just do want to acknowledge that, because that plays into how we communicate with our patients, right? We have to think about our language and what we are projecting to people who may or may not be in the medical field. Even if they're in the medical field, they may not have the understanding of these concepts. As well as, if we're delivering news of an abnormality to someone, the response is going to be anxiety, it's going to be fear, especially when it's a cancer screen that's abnormal. And that every conversation that we have is very nuanced. People come into the office for your 15 minutes of time with them from so many different life experiences and moments in the day. And so making sure that you're setting enough time with people to talk about these abnormalities and the next steps are really, really important. So with that said, when a provider tells a patient that they have an abnormal result, usually it means that the cervical cytology or the cells from the cervix, that PAP, are abnormal. And so we kind of think of a dichotomy of normal and abnormal. When we get to abnormal, I think of it as more of a scale or a spectrum. So I start with normal, and I kind of explain that when we look at these cells under the microscope, they look like how we expect them to look like. And then there's results that cozy up to normal, and these are a lower grade abnormality. It means that they're a little bit different, but they're fairly relatable to normal. And then we go more low grade changes, higher grade changes, and then to cancer. I think that it's really important to have communicated that up until higher grade changes, these are all pre-cancer. So an abnormal result doesn't mean that you have cervical cancer, although that's usually how it lands when you tell someone this for the first time, because that anxiety and fear kicks in. So making sure that we're communicating this well, and that we are going to plan treatment specifically for them based on this result, their age, past results that they may have had, to really tailor it to them as an individual. And the guidelines for management of abnormals that were released in 2020 do exactly that. It's more risk-based now, is how we treat our patients. The other thing is that our results may be HPV positive, negative. And what does that mean? Well, HPV positive, it is a very commonly, it's a very common infection. It is sexually transmitted, but it is so common that I think of it as ubiquitous, almost like the common cold. Most of us have had HPV, but our bodies have either cleared it or, have harbored it for a long time, and now it's just showing up. What we do is we test for high risk ones. And so explaining to someone that you just happen to have the one that we test for reduces a lot of stigma from it, which is also a focus that some people can have when they're thinking about these abnormal results. It's very psychologically very disturbing, and a lot of self-impact can be associated with it. So talking about these results and then making sure that we have a plan moving forward. So next steps are come back in a year and we're going to monitor, or we might need to actually take a sample or a small biopsy of your cervix in the form of a colposcopy, or you might need treatment. And that treatment is to make sure that we catch this early enough so that it doesn't devolve into frank cancer. But I want patients to always ask questions, and that's the bottom line. If you don't understand it or you're not sure of it, ask questions. And if you don't understand what's being conveyed to you, ask your provider to explain it in a different way. Have a support person in with you. Sometimes you're going to need to receive this information at a different time or moment when you can process a little bit better, because these are really abstract concepts. And so the communication skills that we're bringing to the table may not always work. So just to be very thoughtful and intentional and making sure that a patient feels empowered to understand what these mean and what the next steps are.
Thank you so much. That really took some of the mystery out of it for us. And I think really, really sound advice about sort of asking questions and empowering individuals to really seek the information that they need, especially with at a confusing and scary time. So thank you so much for that. And Ms. Pena, you actually answered my question by providing, we were going to I was going to ask about resources that are available in Spanish language. And I think, I just wanted to make the point there that resources are so important. And so I think the more that we can do to share resources that are accessible for all of the individuals that we serve, that's so important. So I know certainly you can go around navigation. I would encourage folks to go to the National Navigation Roundtable website, cancer.org, and other resources like the ones that were put in the chat for the group. We've run out of time, unfortunately. I feel like we could go on forever here with this group. And so I know we had a fantastic discussion. We answered a lot of questions, but not all of them, unfortunately. And so I would encourage everyone, if you had individual questions for a panelist, I know our panelists are really, they would welcome you reaching out and asking questions of them directly, but also you're going to get a recap, you're going to get the slides and accessibility to the recording of the conversation as well. And so I think just lastly, so I just want to thank our panelists. I want to thank you all for attending, but I also want to thank our outstanding panelists. So first of all, our presentation by Dr. Moore, which was just outstanding and really laid the groundwork for us in this conversation today, and just outstanding advice and input and really clarification around some confusing topics from our panelists. So thank you to them. And I'd also, just before we end today, I would ask that everyone that's participating complete the evaluation of our session. This is how we do things better and better each time. So we would really appreciate that. A link will be provided at the end of the event. So I hope collectively you've all learned something today, that it was insightful but applicable to you and your work. And I would just thank you again from all of us at the American Cancer Society, the National HPV Vaccination Roundtable, the National Breast Cancer Roundtable, and the Roundtable on Cervical Cancer. I would also like to thank our ACS team members who have put this webinar together. You are amazing. And thank you all for joining. Have a great rest of your day and a fantastic week. Thanks so much.